been asked to talk about acute presentations. As you know, there are many infective agents, but there are effective treatments for many of these organisms. So if we can make early and accurate diagnosis, it will affect prognosis. So what I want to do today is to look at the anatomical compartments that infection can involve, and then we want to look at the role of imaging, and then I will review the imaging of the common intracranial infections which affect us in the UK. Obviously, throughout the world, there are lots of different infections that you see more commonly, but we're just going to look at the UK today. And then I'm going to show you some interesting cases which I found informative during my career. And if there have been any clinical factors in the history that are important, I've actually put the text in red just for you to become aware of that. So, as in all of radiology, the clinical presentation and the medical history are obviously really important. But with intracranial infections, some of the findings are quite non-specific. You know, without the history of fever, somebody presenting with neck stiffness, headache, and photophobia could have had subarachnoid hemorrhage, but you know, obviously the headache is slightly different. But you know, we have a differential. And when we start to move on to infections that affect the actual brain parenchyma, then patients can have seizures or decrease in conscious level. But again, these are pretty non-specific. And importantly, with abscesses, the patient may actually have no systemic disturbance whatsoever. They may have no fever, a normal blood count, and unless there is actually problems from the source of the infection. So what I want to see now is that with the sources, is that the sources of infection are several. You can get hematologic distress, and that's the most common cause for infection in the brain, but you can get local extension of disease from the mastoid or the eye, as you can see here. You can get communication of CSF with the exterior, for instance, in patients with middle and inner ear disease and in defects in the floor of the anterior cranial fossa. So it's really important from our point of view to look at bone settings in patients with recurrent infection intracranially. And obviously, if the patients have penetrating trauma or surgery, they can also get infection. So what I want to do is to give you 5 cases, and I want you to look at them, and at the end I hope you will actually get the diagnosis right. So this is your first case, and this patient presented with headache, photophobia, nausea and vomiting.
Lights. You asked the projection.
Okay. Can you put the lights down, please? Okay, this is your second case. Pre and post contrast in a patient with acute sinusitis, headache and lethargy. And your third case, pre and post contrast. Fourth case, a lady with raised pressure. And then finally, a 27-year-old lady was 3 weeks postpartum with seizures, and then 12 hours later had that scan. Okay, so by the end, I hope you realise what we're talking about. So CT, fortunately, for this presentation, really is the first-line investigation, and is usually the only technique that we use for pre-treatment investigations. We reserve MR for difficult cases, and we usually use standard techniques, but diffusion-weighted and MR spectroscopy can be helpful, and we sometimes use vascular techniques if we're looking for vascular complications. And what we are hoping to do with CT is we're trying to address several problems. First of all, when we're looking at patients who might have meningitis, the question that we're often asked is it safe to RP? Then if the clinicians think that the patient's got intracranial infection, then we're looking for the site, the extent of the infection, the source. And then obviously CT plays a role in detecting the complications of infection. So the question, do we have to do CT before we do an LP in patients with suspected meningitis? And the answer to that question is no. I know our clinicians often ask us to do it, and they want to see the foramen magnum looking like this. But in fact, even if the foramen magnum looks like this with slightly low cerebellar tonsils, the patients don't encounter any harm from having an LP. And there have been several papers in the literature over the years, and this was just one from 1993, saying that there were no recorded cases of patients deteriorating after LP unless the patients have got focal signs, a decreased conscious level, or papilledema. And in fact, the risk of not doing LP is lower than not treating meningitis. And the important thing is you shouldn't delay treatment waiting for a CT scan. We've actually added 2 more indications for doing CT, and that's patients with recurrent seizures and patients who are immunocompromised. And obviously, if the clinical examination can't exclude any of the above, then you do a CT. You don't need to get intravenous contrast, and it's important that they start the IV antibiotics before they delay. So as you know, meningitis is common. It's usually viral, but it can be pyogenic. Patients may have a prodromal illness and present with fairly non-specific signs, as we said. But if the patient has focal deficits, it's uncommon in meningitis, and then you should be looking very carefully for a subdural empyema. And you can see why the patients get complications from meningitis, and that's because you've got all this purulent stuff coating these subarachnoid spaces, and they're all gummed up, and you get communicating hydrocephalus empyemas, and if not treated, progressing to cerebritis and abscess, etc. So normally, if we do an CT, and we do them within working days, but after midnight we don't do them, we say unless there's a contraindication, just get on and treat the patient, we'll scan the patient the next day. Then the CT is usually normal, but you may see hydrocephalus. The thing about hydrocephalus is that, okay, if the clinical scenario is correct and you see hydrocephalus like this, you can say it's communicating hydrocephalus, most likely to be related to meningitis. But if you haven't got that history, don't forget that the patient may have had a subarachnoid hemorrhage as well, so the patient definitely needs an LP to make the diagnosis. If the patient then starts to deteriorate neurologically, and it may be because they're a patient at risk, because they've got orbital abscesses, frontal sinusitis, etc., they start to develop seizures, then we're obviously thinking about the possibility of an underlying subdural empyema. And if we don't make the diagnosis and the disease progresses, then we're going to get involvement with cortical veins, with infarction, raised pressure, and obviously a mass effect from inhalations. So I'm going to show you some cases, and this is a 9-year-old boy who had an upper respiratory tract infection, and he had frontal headache. And he had an onset of periorbital swelling and fever, and you can clearly see the preseptal soft tissue swelling, but also on the chromally formatted images, the periosteal collection. Because of the fever and the headache, I would always do an enhanced brain scan, and you can see the very shallow subdural empyema in this patient, which obviously has to be treated. And with multi-slice CT now, we can get nicely formatted images, and not only can we see in this patient that they've got supratentorial infection, but they've got infratentorial infection. I just want to point this sign out to you. This black line against the fox is a subdural empyema until prognathosis. I think that's what the diagnosis is invariably. So if you see that black line, particularly in patients at risk, that's what you've got to think about and get some reformatted images. Obviously, if you're worried about it, you can always do a T1 post-contrast MRI scan, as you can see here, the outline of the subdural against the fox. So this is a 70-year-old man. He was found on the floor. He had a minor head injury. But he also had a slight fever and a discharge in ear. Now, lots of people would just see this, or people could see this and say, okay, he was found with a head injury, he's got an acute on chronic subdural hematoma. But the history is there. You know, he had a slight fever, he had a discharging ear, and you have to look at the bone shots, and here you can see the pacification in the ear. And this was a subdural angioedema, it was not a subdural hematoma. 22-year-old with a discharging ear. We've given the patient contrast, and you can see the abscess in the subcutaneous tissues. But you can also see that there is a small extraaxial collection in the posterior fossa. There is an infection associated with it. But look at the venous sinus as well. And this patient had a couple of pathologies. He had an epidural abscess and a venous thrombosis. Now, if I have a patient like this and I've looked at the request form and sort of that's the clinical scenario, or mastocytosis or whatever, I actually give the contrast as a CTV acquisition, and then reformat the contrasted scans as the head scan. You're obviously not using any more radiation, but it does give you the information, looking at the source data, of the extensive thrombus within the superior sagittal sinus and torcular, etc., going right the way down. So I would just advise you, if you've got that clinical scenario, do a CTV and just reformat the images, and you'll get all the information about the potential complications. A 7-year-old boy admitted to A&E. He had a 2-day history of an upper respiratory tract infection, red eyes, and he had fever, malaise, and headache. And these are his scans, and you can see the widespread sinusitis, but also the bilateral abscesses. And his head scan, which I would always do with that clinical scenario of fever, malaise, and headache, shows that he's got an extradural hematoma there. He was treated with antibiotics appropriately. They weren't as quick as they could have been, perhaps draining the sinuses, but he improved. However, he continued to spike fevers and had 2 seizures. And if the patients aren't responding and they start to develop new neurology, then it's important that you re-image the patient. And now he's got bilateral epidural collections. So even though the eyes are improving, you can still get progression of the intracranial disease, which needs to be treated. So epidural and subdural empyemas account for about 20 to 30% of intracranial infections. We commonly see it in patients with sinusitis, mastocytosis, orbital cellulitis, can be related to craniotomies. Focal deficits are uncommon with extradurals, but are common with subdural hematomas, and there is still a mortality from patients with subdural hematomas. When patients develop involvement of the brain parenchyma, which is uncommon, it's usually due to hygienic infection, but the area of brain that's involved is first of all a focal area of cerebritis, which develops into an abscess over the course of about 2 weeks. And as we said previously, it may have no systemic response. So depending on where the source of the infection is, you may get an area of cerebritis involving the grey-white matter junction or at the site of the primary infection. And when the patient is still in the cerebritis or has a small abscess, then the surgeons will treat the patients with antibiotics. However, obviously, if they don't respond, then they may have to go on to have surgery. And they usually will have clinical improvement before the imaging improves. And this is a 14-year-old boy who was treated with otitis media a month prior to having a scan done, and then presented with ataxia, vomiting, headache, and papilledema. And he's got a ring lesion in his posterior fossa. With that history, he's also got hydrocephalus, as you can see. With that history, you'd say that this was a cerebral abscess. And another patient with sinusitis, with a seizure, a ring lesion, and another frontal abscess. So with the improvement in diagnostic imaging and the treatment options, then the mortality has really decreased from cerebral abscess. However, we're still seeing patients who need to have surgery to excise the abscess with a mass effect and to confirm the diagnosis. and if a lesion isn't responding to antibiotics. So these lesions are ring lesions, and it is hard sometimes to, without the right history, to know exactly what you're dealing with, because primary and secondary tumours can also be ring lesions, as well as abscesses and other pathologies, as I've listed here. And I've had a patient who had a CA then, but also had SBE, and had multiple quite large ring lesions throughout both cerebral hemispheres. And you get a feeling, because of the clinical problems, or lack of clinical problems really, was that we were dealing with multiple nets, but in fact we had multiple abscesses which were eventually drained. So the clinical presentation, it can be difficult to differentiate them, and also on standard imaging it can be difficult. The MRI has been helpful. The advocates of MR spectroscopy will say that they can diagnose and differentiate abscesses from tumours. You can in the vast majority of cases, but not always. And surgery is obviously the best at differentiating them. This is the typical picture of MR spectroscopy of this patient who had an abscess taken from the journal with the low NAA and the succinate and lactates and acetates. Diffusion weighted scanning, I think, is more helpful, and obviously in the DGH setting you're much able to do this. And we find that there's restriction of diffusion in the centre of the necrotic axis on the DW, and the ADC map shows this restricted diffusion and can be used therefore to differentiate them. And if I had to put everything together with the complications, this is the one patient that really brought home a huge lesson to me quite early on. He was a 17-year-old boy, and I remember talking to him outside the CT room. He'd been sent down from the ophthalmology clinic with the eye here, and we scanned him and saw this large subperiosteal collection, and also the extensive sinus disease he's got involved in his sinuses. I was chatting to him, and he gave a history of neck stiffness the week before, which hadn't been thought of by or hadn't been detected or wasn't on the request form. And so I'd done a head scan, and you can see that he actually has got Herpes, so he had meningitis related to this infection. And if you look at the date here, he got admitted because of that and was given IV antibiotics. And the next day he had a fit, and he's had an MR scan, and you can see that he's got this increased signal in his inferior part of his frontal lobe, and on the coronal and sagittal imaging he had enhancement sort of coating around the pituitary fossa. He didn't have any big, or didn't have an abscess with a well-defined rim yet. But a few days later he was obviously treated with IV antibiotics. They drained his eye, but they hadn't treated his sinuses. They hadn't gone in and washed out his sinuses. And he just progressed and developed this frontal abscess, and then developed venous infarction, and in fact died. And I think now, when I see these cases, I just always make sure that they're treating, they're treating the patient. They drain the eyes, and they also treat the sinuses as well, because if you don't treat them, they do progress, and the results aren't good. Encephalitis is an acute focal inflammatory disease of the brain. Can occur with direct invasion or as an immune-mediated response. It's usually viral, and the common one that we see in the UK is Herpes simplex virus. And the patients will present with confusion and seizures, and the symptoms usually localised to the frontal and temporal lobes. The patient may be febrile, and the virus tends to affect the limbic system unilaterally, first of all, and then bilaterally. If these patients aren't treated again, there's a high mortality because of the patient developing hemorrhagic necrotic meningoencephalitis and vasculitis. So, if there's any clinical suspicion that this may be the diagnosis, that patients are treated with on clinical grounds by a cycloplegia, we we do image the patient. CT and sometimes MR is normal in the early stages, but as the disease progresses, then you do get changes on the MR and eventually on the CT. And the problem with herpes is that serology and CSF can be normal within the first couple of weeks. So this is a normal CT of a patient with herpes simplex, and the MR showing the gyroedema on one side in the temple, but then you can see both insular cortexes and the frontal lobes are involved as well. And another patient who progresses and develops quite marked atrophy with involvement of the temporal lobes, insular cortex, frontal region, and singularitis, as we commonly see the involvement. Unilateral involvement is quite common, but we often see it extending on MR to the outside. Now, I'm not going to dwell on AIDS-related infections, but just to say that these immunosuppressed or compromised patients are at risk of getting quite a lot of infections, you see. But I just want to touch on the patients that we see acutely coming through A&E, and these patients have usually got AIDS, but they haven't been diagnosed yet. And in fact, 10% of HIV patients will present with CNS disease as their AIDS-defining illness. Many attend the GP and A&E and have been there for the last year or so, but nobody's actually made the diagnosis. And these patients' CD4 counts are usually very low, and they've got advanced HIV. And the question that is usually posed to us is that, have they got toxo or have they got lymphoma? So is there a mass effect? And if not, they need to do an LP on the patient. The toxo-titers are usually not very helpful, so they usually treat the patients empirically. Toxo is far more common than lymphoma. A single lesion, they say, is more common to be lymphoma, but not necessarily the case. Lymphoma is obviously, hyperdense on CT, so you can see a lesion which may be involving the corpus callosum or periventrically. There are advocates of MR spectroscopy, but at the end of the day, these patients are treated for 2 weeks and re-imaged, and if there's no improvement, then they go on to biopsy. And this is such a patient who has a CT scan with this large lesion. The capsule of the toxo hasn't well formed yet, but that was the diagnosis. He was treated empirically for 2 weeks, and he responded to treatment. These are the end results of after several months of treatment. We are still seeing a little bit of TB in the country. It's obviously a problem in developing countries, but we see with immunocompromised patients, drug users and the homeless. It's usually from hematogenous spread from pulmonary infection, and they can get a meningitis or tuberculosis or abscesses, and it's a great mimic sarcoid fungal infections and lymphoma. Patients we see have usually got personality changes, they're anorexic and listless, they get a headache, and they can be drowsy with neck stiffness and multiple cranial nerve palsies and seizures. And this was a 9-year-old boy who presented with a headache and confusion and multiple cranial nerve palsies. And he had raised protein in his CSF with raised white cells and low sugar. And his CT and the subsequent MR showed that he had a communicating hydrocephalus. He was given contrast, and you can see the prominent meningeal enhancement that he's got. And basically the whole of his subarachnoid space is infected, and he's got meningitis. And he went on to develop a vasculopathy and multiple small infarcts in his basal ganglia, and obviously communicating hydrocephalus as a result of the disease process. Sometimes we scan patients and see with TB, pulmonary TB, and see multiple ring-enhancing lesions such as this, and these are multiple abscesses within the brain, and this is called the target sign, the central hyperintensity and the rim of hyperintensity around it. So if you see that, think about TB, but it's not absolutely pathognomonic for TB as it was once thought. Okay, so let's look at our cases finally. Any ideas what's going on here?
Meningitis?
It is meningitis. We didn't have any relevant history beforehand, and when this came through, it was thought she came over to us from another hospital with a subarachnoid hemorrhage was what we were told. But obviously you can see that she's got dilated ventricles, communicating hydrocephalus. You can see that her systems are all slightly high density, so you can appreciate why somebody thought it could have been a subarachnoid hemorrhage. But that's not really, that layering in the occipital, it isn't really bright enough for that. And she definitely had a pneumococcal meningitis. Okay, case 2 was the person with acute sinusitis, headache and lethargy. Got pre and post contrast scans. So now you know what the diagnosis is without me looking at the pictures really, because of what I just said before. And I think, can you appreciate the very shallow subdural hematoma on the surface of the hemisphere there? They didn't believe me actually for this one, so the patient wasn't treated for a couple of days, and 3 days later, that's the scan. So now you can see it, but also it very nicely shows that black line sign that you get against the faults in patients with subdural empyema. So if you see that, think subdural empyemas. Okay, this is a recent case that came into the neurosurgeons, I think the weekend before last, with a ring lesion. Okay, so there's a differential diagnosis for ring lesions, we've discussed that, and that's the chest x-ray. So she was sent over with a temporal metastasis that needed to be, or could be excised because of its location. But anybody got a clue? Yeah, you can see the prominent vessels there. This is the patient that we did do MR on. You can see the lesion ring enhancing on the T1, and the DW and the ADC maps showed the restriction, and that was an abscess. And she obviously went on and had a pulmonary angiogram as well, and she actually had hereditary hemorrhagic telangiectasia. How somebody didn't spot the spots, I don't know, but and with multiple, with a pulmonary ABM, obviously these patients are at risk of getting multiple brain infection. Okay? Perhaps I didn't give you that she'd been recently diagnosed with HIV. Perhaps just another clue now. So it was a ring lesion, but it's slightly funny. It's got some central, and this is actually a big tuberculoma, which actually went to theatre to exercise because of the massive head. And this is the worst case, and you really take something home from this case if you can. She was 27. She was 3 weeks postpartum, and she came into that scan, and she went off. And so we repeated the scan at 12 hours, and that's the scan there. And you can see she's got diffuse cell. I think when she came in with this, they thought, oh, she's got venous sinus thrombosis, because that's usually what they have, that 3 weeks postpartum with seizures. But there was no evidence of increased density here along the, or in fact, she didn't have CTE, but there was no evidence of that. And she's just got diffuse swelling there. So if you've got a patient with a normal scan, or you don't know, you can't work it out, there's obviously something wrong with the patient, but you just can't work it out, then do MR, and that's the MR. What I hope you appreciate is that the T2 isn't really very helpful. If you look at the flare, okay, and look at a normal flare, can you see that the subarachnoid spaces are all bright, whereas they shouldn't be? And basically, she had meningitis, and she passed away, unfortunately. But it was fulminating meningitis. So, you know, if you've got somebody who you just don't understand, at the end of the day, you might have to do an MR and sort it out. But, So in conclusion, what I hope we've done is we looked at the imaging to identify the anatomical compartments involved with infection and the potential complications. You know, the question of is it safe to LP, unless there are contraindications, yes it is, you don't have to get up at 3 o'clock in the morning. If there are any red flags, then look for subdural and epidural empyemas, because otherwise you might miss them, and look for the source of the infection. We've reviewed the imaging features of infections that we commonly see in the UK. It hasn't been all-encompassing. Note the history of the examination. It's important to us as clinical radiologists, and just beware of the normal scanning of a patient with decreased conscious level. And as radiologists, we often can make the diagnosis, and prompt treatment can make a difference. Thank you for listening.